So yeah, I'm sharing the screen. It should be this case. Yes, we stopped that. It could be yes. This is case of sarcoidosis. Yeah, and as you see, the sarcoidosis osseous involvement is not common, as you see, and this honeycomb or lace-like or whatever in this pattern is characteristic. Maybe sometimes acrosteolysis, so included in the differential of acrosteolysis again. As Dr. Marwa, I see that she gave us this differential, yes, spina ventosa of TB and other granulomatous infection would be good differential. Cyst-like appearance, you put tuberous again, tuberous sclerosis, yes, in chondromatosis and fibrous dysplasia, and any hemangiomatosis and hyperbara. At least if you mention hyperbara and enchondromatosis with fibrous dysplasia, I think it's very nice. Okay, let's take some cases. So what about this one? Yes. Again, our yes bone, yeah, with soft tissue. Yeah, you can see the soft tissue tumefaction, right? And you can see also the bone, yes, affection. So there's bone affection, there is soft tissue. So perfect. So everyone maybe is now is maybe you just go to the 3. Yeah. So spina ventosa, one of the good differential. What else? We just mentioned some of them. Complicated enchondroma, but where is the calcification? As you know that enchondroma should have some, maybe we don't have this appearance, so maybe yes. Osteomyelitis, very good differential. So this one is the TB dactylitis, which is should be not common, but yes, it can happen. So the infection in general, and again sarcoidosis, again yes. So let's go to one, maybe it could be easier case. I hope so. And I think here this is the fibula. So this lateral tibial condyle, lateral femoral condyle, medial and medial. Okay. So here if there is one, yes. Any questions? Okay. So we are checking the menisci, right? If you are checking your menisci and checking again the ligaments, yes, and there's some effusion here, yes, and some edema here, and the posterior cruciate ligament, right? So in the coronal, maybe it's not easy to recognize something, but let's try to check everything in this knee. Here's axial cuts. So maybe I stop here and check, yes, the ECL and BCL, right? Is it in its place? The signal, yes. Again, the effusion. Let's go to the proton density with fat suppression. Again, maybe something going here. What do you think about it? Let's have here the sagittal maybe help us. Yeah, I think the sagittal have the key. So if we consider this one, the ACL, yes, the BCL, sorry, this is the posterior cruciate ligament, yes, and we are trying to figure out where is exactly. So this is the double BCL sign, where you find this one and you find this one. So they like it. So to be honest, you should know it from the coronal. You shouldn't wait, because you can see clearly that the meniscus here is incomplete, and you can see that the fragment is going through inside. Yeah. Yes. Sorry. Yeah. In the intercondylar notch, you can see that there is fragments inside here, beside the posterior cruciate ligament. So when you find this, is called, it should represent bucket handle. Yes. So you can see the medial meniscus here is incomplete and torn, and part of it is placed in the intercondylar notch, and it go behind the, yes, in the intercondylar notch in front of the BCL sign, and it gives you this appearance of double, yes, BCL sign. So when you find this double BCL sign, which is here is more clear in the sagittal, you should go. So here you can see the meniscus is torn, yes, and the fragment here is going in the intercondylar notch, yes, here. So this is what is called the bucket handle tear with the, like it in the exam. I think you will find this one in the simulation exam, similar to this one in the simulation of the exam of the ADIR, yes. They like this very, very much in the MCQ and in the short questions, long questions, but I think it can come short more and with also MCQ questions. Exactly. So when you find one fragment here beside the lateral tibial condyle, so this one is C-bond, and sure he will ask you about ACL tear, what you would like to do after, or what this represent. It's associated like with much more than, maybe, I don't know, but I think that it's very, very frequent to be with ACL tear, yes, anterior cruciate ligament tear, yes. So C-bond fracture, one of the very common tips in exam. Let's have this one. Again, our question, is it bone joint? So I can see clearly that from the CT that is bone lesion, and this bony lesion have, yes, expansion in the bone. So what differential you will put in your differential? Yeah, you can put hemangioma, but also you can include fibrous dysplasia, right? Especially with the apparent with ground glass veining. But to be honest, this patient is, yes, interosseous hemangioma, which is biopsy proven. So yes, well, I want to show you that if you say fibrous dysplasia, and yeah, most important to say that is non-aggressive lesion, perfect, because you can see that is narrow zone of transition, and there is no cortical breaching, no preosteal, aggressive preosteal reaction, and no soft tissue component. So you are talking about a non-aggressive lesion. Then you mention some differential, including what we said. Then finally, you can say that is hemangioma. So again, I think now it will be easier if you find this appearance with the ground glass appearance, which is typical. Yes, fibrous dysplasia, one of the giant titles in the exam. Then he will ask you about many questions, maybe about the associated syndromes like McConnell-Bright. We mentioned it in the neuro, McConnell-Bright, and maybe this patient will come with many clinical features. So put in your consideration, and Mazar-Browd with myxomas, exactly, if you find myxoma. Again, if you shift to this case, again, you will mention what we mentioned now. It could be fibrous dysplasia if it is bony lesion, right? So you will consider it as bony lesion in the rib. So you'll mention fibrous, but what else? What could be? Could be metastasis, maybe, but not very typical. Maybe this appearance with the like sun ray appearance a bit, so maybe it's not very benign. Maybe it's going with maybe maybe enchondroma, hemangioma, Ewing's, but also maybe plasmacytoma. So you'll the description in this case is very important to mention that speculated, expansile, and there is no destruction. Yeah. So non-aggressive, yeah, maybe non-aggressive. So if you find like this, yes, plasmacytoma is old. So this one was hemangioma again. So put some differential and say that which type of uh, is it aggressive or not aggressive? If not aggressive, then you are going with something more benign, right? So yes, let's go to another case. They like it in the MCQ again, and it can come short question as antimony, and he can ask you something, maybe the next step. So he show you this one. I think now it is easy to, yeah, too easy. Yeah. When I say next step and I show you this, it is easy. But when I show just this, then when you find this widened tibutalar joint, yes, then you can say that Maisonneuve fracture. Someone is he's French. Yeah. So what could be this one fracture that you should check the proximal fibula, because they are associated when you have by the mechanism of injury. You will find this one is widened and this one is fractured. So what you should ask this patient, you should ask for proximal tibia view. So you will ask to, yeah, X-ray for the upper leg exactly and the knee. Yes. So you'll find that there's proximal fibular fracture, and this is what is called Maisonneuve, or yes. So let's go to the next. Yeah, if it is, he show you the proximal fibular fracture, you should go down and check the ankle. So you'll ask for X-ray ankle if it is the reverse. So another checklist, when you find X-ray, you will go to your checklist. And is it bone or joint or soft tissue? Then if it is, then you can consider what it could be. But so let's have, yeah, this is one of the antimony cases. Yeah, you will find this calcific or ossific area beside the medial, yes, medial femoral condyle, and you find this one, this is Blegrina Shida, yes. So ossification beside this margin, you could put Blegrina, which is antimony case, yeah, and it can go through differential of soft tissue calcification, okay, perfect. Let's have another look for this case. Yes, so this one, to be honest, it come in other views. Maybe sometimes it come more easier than this. Sometimes, yeah. This is the OCD, osteochondritis dissecans, maybe in later form. When you find the appearance in the, especially if it comes characteristic site here, sometimes it come here. So whatever, if you find the osteochondritis, especially if the patient is young and you find this lesion, which is type of osteonecrosis, so yeah, you put differential also of osteochondral lesion, yes. So osteochondrosis scans, one of the antimony cases, and they have grades. I think this one maybe with this sclerosis and abnormal changes with osteoarthritis, yeah, maybe in late or advanced stages. So this one is OCD. Yes. And in older patient, maybe you consider insufficiency or song. We will see what is song after a while. So what it could be, yeah. And here the Y view, the Y view, yes. Okay. So this patient underwent X-ray, and after he did this X-ray, I don't want to go to the next. Maybe I will stop here a bit. If anyone can figure out what is going. So let's go to the next bone scan. And he find this appearance with this, yeah, this hot area. Yeah. So maybe someone have suggestion for something. I think now it is more easier in the MRI. So let's check what is going in the MRI. So before you want to go to CT again, to the X-ray again, or to continue. We find this lesion. Yeah. And maybe I can show you this appearance. Yeah. Yes. Maybe in the axial. This is the long head of biceps. Yes. So this is anterior, this is posterior, and this is the humeral head, and this is the part of the scapula. Yes. And here should be the glenoid, right? So what is going here? Anyone recognize in the T1? Yes, is here. So this is the lesion. Is it? Yes. Is it bone? Again, your question is going. Is it a bone, soft tissue, is something? Yeah. So this appearance, you will describe it. One of the important description to talk about the affection of the bone, is it included or not? And if there is any, yeah. So I see that from the comments that maybe there is some synovial pathology, maybe barostial lesion. So sure that you want to know the age of this patient is going with barostial, maybe not. But let's have a look in this. There is another lesion here also, maybe. So let's check what is going in here. Yeah. So yes, I think everyone now. Yeah. So this is chondrosarcoma. So why chondrosarcoma? This patient make excision, and finally they find it is chondrosarcoma. Very high, exactly. This is the key. So when you find in the MRI this very high T2, someone say that maybe synovial, maybe yes, but don't forget the calcification and the chondrosarcoma. The chondrosarcoma is very tricky, especially if it come like this, very odd. And maybe I can show you now the history, if there is any history. Yeah, tenderness for a fall, then nothing after. The patient age is 30 years male. Yeah, and I am coming to the X-ray. So what is this? No one commented this. So this is important when you find, yeah, that there is something going here with maybe calcification, and I can see that there is expansile calcified ossified lesion and projecting medially. It's continuous with the bone. That's in X-ray, and here you cannot. He say that the wide zone of transition, like you cannot see any different borders between the lesion and between the abnormal area which is affected and normal area. It's like ill-defined, yes. So when you go to the bone scan, it take taking the bone scan, then finally, when you find this, just put in differential. Chondrosarcoma, especially if you find something high in T2. Okay? Is not typical case, but just put a case, and also, yeah, especially, yes, if it go through previous osteochondroma. So, yes, so this is what is called malignant transformation of perfect. This is what's called malignant transformation of previous osteochondroma. So if this patient, for example, have previous X-ray, you will check the previous X-ray, and you will find that, for example, he have osteochondroma, but after that, it have malignant transformation. Then in MRI, there will be very good question in either an MCQ about something called the cartilaginous cap. So if it is exceeding more than 15 millimeter, I think so, 1.5 centimeter, so you are going that this patient underwent malignant transformation. So osteochondroma, one of the good differential, especially if you have any previous, and when you see this cartilaginous cap and it is exceeding, and not just exceeding, it transformed to soft tissue. So this means that this patient developed malignant transformation. This one of the antimony case, but this is tricky because the other differential with this case will be very dangerous. So either metastasis or osteopiclosis. Yes, osteopiclosis. So one of the good differential to put. Look in the CT. Yes, you will find like many bone islands, which is the osteopiclosis appearance. But the most important to ask if this patient have any history of primary, because of this patient have, for example, history of breast or prostate cancer, either male or female. I mean, for male prostate and for female breast. So you will get again this appearance, which is osteoblastic metastasis. So be very careful. And maybe you can check the other region of the body. Yes, and also if this any bone scan, then you will check the bone scan, and maybe you go to check other region of the body of the, for example, the metastasis, the areas where the metastasis like, but the osteoporosis maybe include everywhere, so it is just one island, so it can, yes, it can include everywhere. Yes. So this is one of the good example that, okay. I think we can go to the frontal or X-ray view. Yes, frontal view. So where is it? I see in the comment something about coalition, but I don't agree because I cannot see any coalition. Although the coalition have like something, give you some signs. Okay, so yeah, exactly, yes. So let's check the alignment. Yeah, there is something here in the alignment of this joint. Yes, and this is what is called this fracture. Yeah, you can see in the X-ray that, yeah, sorry, the CT, that there is multiple fractures, and this patient underwent operation. Yeah, there is two types, homolateral or divergent type. Yes, so you consider it like homolateral, okay? Anyway, don't forget less frank, and one of the important top checklist when you check the foot, to check first for the less frank. Yes. Again, another more advanced less frank, but is like you can see that there is much widening and disruption in the joint. Yes. So when you find this less frank, it is like anti-mini case. Don't yeah, don't step out of it. Yes. Let's go to quickly in this case. I see that probably some of us is a bit exhausted. Okay, I'm trying to go quickly, not very quickly. Maybe I will shift it to, yeah. So I think also the image, yeah, when you have this, the femoral neck with the head junction is short, like this case, and you find that there is some bumpy appearance or maybe some swelling here. So you are thinking about one of the FAI or femoroacetabular impingement. So the femoroacetabular impingement with this appearance, very tricky because many of us consider it as a normal. So you will check it in the coronal, especially if come to it in the X-ray, it is more difficult. So this is femoroacetabular impingement. Here, when you get this case, it's more easier for you to check the coronal image, but the axial also may be helpful. And you will get many questions, either MCQ or short again. Yes. Maybe I'm fixed now to fix the image in this appearance to check the answer. Yeah. So what it could be? What it could be? Yeah. So you can send it in public. I agree with you. Yeah, you can send it in public. We are making just like a chat or talk, so don't worry. Yani. We talk freely. Yeah. Well, okay. So a very good question they ask you in the exam about the muscle attachment, and they want you to be aware of the muscle attachment if you have any insertion, tear, or injury. For example, the anterior superior iliac spine or the anterior inferior iliac spine. So the superior, you will have the sartorius muscle. For the inferior, it will be the rectus femoris, right? And you will go through many of them, and don't forget that the pubic tubercle, it will be the adductor muscle. Yes. So the adductor muscles, it's inserted here, and you will find in the textbook very good. For example, here the iliopsoas, the lesser trochanter, the greater trochanter, it will be the gluteus maximus, and so on. So you will check this muscle attachment and check if there is any edema signal connected to this abnormality. Okay, especially if you have tear like fluid signal and there is some interruption in the muscle fibers. So in this case, you are going to be maybe more advanced. Yes. So this patient have I just go, I think it's adductor injury, adductor muscle injury. The hamstring is the No, the hamstring avulsion is in the ischial tuberosity, not in the pubic tubercle. Okay, but you should be aware of them. Every avulsion, they like in the exam. They like it very, very much in the any exam you will get. Okay. Let's go to this case and yeah. So again, our question is it bone or yeah or joint? So I think that you agree with me that there is something here which is bone, yes, and you can see that yeah there is some sclerosis, and this sclerosis continuous with the cortical outline, and here yes. So do you like to suggest anything, or I go to next? Maybe melanocytosis, maybe, and but yeah, the bone scan give you this appearance, and he tell you that there is some osteoblastic lesions with high uptake in the right 6 ribs and 6 rib and T9 L1 on the left side. So yes, so you have something that going with to be yeah that give you that maybe it's metastasis, right? Good differential, okay, and here you find like something lytic. Is it narrow zone of transition or wide zone of transition? It is narrow, yes, narrow zone. So lytic lesion, and you can have something inside here, yeah, and there is sclerosis, yes, but there is no bony breaching. So bony lesion, and you have suspected to be something going. Let's check the description. So this is, as we mentioned, is non-aggressive. So you are checking non-aggressive lesion. The most important to say that is narrow zone of transition. There is some expansion, but no periosteal and no extraosseous masses. Yes. So this patient did MRI. Some of us, like he mentioned, some yeah, good differential to good fibrous dysplasia. Good that you put in your mind that maybe something benign. That's important. Yes. And here, who tell me that maybe something lipoma, this is the fat set. So it's still high and give you this appearance. So it is not lipomatous, right? It is low in T1, high in T2 with fat suppression. Good differential, again, fibrous dysplasia. Is very good expression they mentioned in the MCQ books that long bone in long region in long bone, yeah, one of the good differential will be fibrous dysplasia. Again, this appearance, this is the most contrast. Yeah, maybe, but why is lipid? I can show you that the fat suppression here is high. So as I think is not lipomatous, because if it is lipid, it will be suppressed. It will be black in the lipid type, right? You agree with me? So it's important to mention the signal and description, and if there is enhancement, there is mild enhancement, and there is some expansion, no fluid level, and no cortical breaching. This is very important. Okay, so no lipid, and you agree with me that there is no lipid component here? Yes, thank you, yes. So, and he's mentioned that there is a smaller lesion, similar signal criteria is in the acetabulum. Okay, so what it could be? Yeah. This patient did biopsy and they find this lesion is fibrosis, no evidence of malignancy. And he asks you, look carefully, and you will see second similar lesion in the acetabulum. So what is your differential now? Okay. So what is your differential now? Yes, this is the acetabulum. Again, fibrosis. So everyone is like fixed with fibrous dysplasia. So this case, the multimodality imaging with patient with no metastasis, yes, and this patient was followed, yes, fibrous dysplasia, followed up to 1 year after this, he has cerebral metastasis. So very nice case that when you have like metastasis, don't go that okay everything is metastasis, and don't go also to underestimate the lesion, but carefully check it. And there is any comment in voice, okay, I can make unmute again. So this is the x-ray again. Yeah, I hope everyone enjoyed this case. It's a bit tricky. We have just 3 minutes. I don't know if we can finish. Okay, so if any question, if anyone want to ask some question, I think this we should keep it in the next time. This one is very nice case, can come to you. They like it in the exam, like so much. And this image is the key. When you see this appearance, I suggest you to go to the gradient. If it's long case, yes, go to the gradient and you see this black or blooming artifact. And when you find blooming or black artifact, or in either in T2, you will find this black signal. So one of the good differential, it will be pigmented, very nodular. And when it's extra articular or near to the joint, to the tendon, so it is called, what is called? Yes, what's the name? The other name of this pigmented giant cell tumor, exactly, perfect, yes. So the giant cell tumor of the tendon sheath, it is just extra articular pigmented nodular synovitis. So it's the same, yeah, they are the same. So when you find it, so why the cause of this signal, why it is dark? Because of the, what is the cause of causing that in the T2? What is the reason in the T2 it's dark? Yeah, the hemosiderin deposition. Yes, exactly. So this is giant cell tumor of the tendon sheath. It comes beside the tendon, and it is localized form or pigmented filionodular synovitis. Okay, I think now this one, it will be easier. I think the X-ray, previous X-ray, if you find, yeah, slipped capital femoral epiphysis, but in MRI, I think the MRI is more easier. So let's finish our session today. I hope everyone enjoying and staying safe. And if any question or any suggestion, inshallah, either here in the group. And I see that some people like to draw. Okay. Let's arrange with the cardiac, inshallah. I will try, but I think the cardiac in the EDIR is not like the priority, because even it is in the simulation exam, they have some cardiac cases. It is like the most common cases come, like the left cardiac myxoma, or for the tumors, or but they don't go to the details, the cardiac details. From my experience, but maybe